And we're back with another PCBH Corner. We have a fantastic topic. It's one that we have talked about a little bit on a previous PCBH Corner dating back maybe 4 or 5 years ago. And I think that it's a topic that is worthy of bringing back. It comes up on the listserv. It comes up when we do consulting. It comes up all of the time. And that is the identity shift that might be involved, we would argue, spoiler alert, it is involved. The identity shift of becoming essentially a behavioral health provider and then having a new identity of being rooted in primary care. So we've been on a little bit of a kick, you know, coming off of the Bob Phillips PCBH Corner talking about high quality primary care and that wonderful piece that was released in 2021 about high quality primary care and defining it. And ever since then, it's kind of given us a North Star. So you were one of the very first people that I've heard articulate this super good about what it means to have your identity being rooted in primary care versus as a behavioral health specialist. So can you walk me through a little bit of?
Yeah, you know, and this would be, this is something we actually ask our fellows. We just went through the initial interview for our fellowship at CHCW. And one of the questions I always ask them is like, hey, you know, if you know, say a family member or a friend came up to say, hey, Bridge, you know, I know you're a psychologist and you work at that health clinic, though. I think it's a primary care clinic. You know, just what are the goals and the purpose and the function of primary care? And, you know, even for people that are watching, it might be good to just pause a video and just allow that question to resonate. It's like, if you work in primary care and you're a behavioral health provider and someone asks you that question, how would you define that? You know, how would you go about it? So I think the biggest thing is we always talk about how this is such a transformative part of integrating within a system is that you need to know the values and the purpose and the function of that. And then almost kind of embracing that as your new professional identity. And so if we look at primary care and primary care's identity and the purpose and the function of it, there's a lot of different definitions that we could do. The two that we always fall to is the implementing high quality primary care that we'll talk about. And then the other one is the 4 C's of primary care. And we talked about that in the first video of whether it be having first contact with patients, so really valuing accessibility, being able to get people into the clinics, continuity of care, so having relationship throughout someone's lifetime as well, sharing information amongst providers and specialists, comprehensive care, seeing all conditions, all behaviors, whatever it might be, all ages, to really make sure primary care is that place that you come for everything. And then coordination of care, that you're helping coordinate care. And even when you're coordinating care with other specialists or referral things, you never stop being that person's primary care.
And those are the 4 C's of primary care as one of the North Stars, essentially. Okay.
And so I think that's an important one when we start this conversation about how that differs a lot from how we're trained as behavioral health providers. Because as behavioral health providers, our identity, while we don't talk about it a lot, is very specialized.
Yes.
You know, it's interesting. I've always thought about this within, you know, medicine. There's so many different specialties, right? There's so many different specialties. And within behavioral health and psychology, there's different specialties for sure, whether it be like neuro, forensics, you know, all these different things. However,
family maybe.
Family, there isn't like a primary care version of an identity within psychology. It's growing a little bit more, but it's not a common one.
Oh, definitely isn't, and it definitely historically wasn't, which is part of the whole problem. Isn't it crazy that we don't have a primary care version?
When you pause and stop and think about that, it's mind-blowing that we don't have a version of behavioral health that is based on being first contact, continuity of care throughout someone's lifetime, comprehensive care, and then coordination of care. We haven't been in the conversation at all. So this is where it's like having grace, love, and compassion, because you can see why then when you start to integrate behavioral health providers within this setting, like primary care, that is defined and has these goals and these functions, there's a mismatch. There's like not an understanding of what goes up. Where's your mind going with that?
Well, that's exactly where my mind is going. And I know Naftali talks a lot, Naftali Serrano talks a lot about one of the very first things you're going to do is level set with the goals of the organization. I know that you and I have started doing a lot of that. We've talked about that a lot in our lab. I'm just kind of getting that alignment, the values alignment, and understanding whatever system that you're in or you're attempting to integrate into, you need to know why that agency, that organization even exists. And starting there, instead of trying to make that organization become more like specialty behavioral and mental health. And Jeff Ryder talks about that. He's been a huge mentor. So these aren't like our ideas per se. Right. This is like years of kind of coalescing these different ideas, hearing this, hearing that, and it kind of all coming together of saying like, it can't be about us trying to change everything into specialty behavioral and mental health. It needs to be about us adapting to the setting, looking at those overall goals and saying, how can we utilize the skill set to be able to, and in our case, we're kind of tripling down on primary care and high quality primary care, to be able to reach a lot of people and provide, really good first line treatment.
Two things in my mind went to that I loved you saying, and this is what's always so fun to do these corners, because we get to talk and then our minds are just going nonstop. The one thing, this might sound too harsh, so let me know how this sounds and stuff. If you're watching this video, you are trying to make primary care more specialty. Like the probability of a behavioral health provider going in, I know that's harsh. I know that is
I mean, I know we talked about it in our first video. We did the same thing. Because it's not even on your radar. It
is just a natural thing that you're going to do. And even we talked about, and I was talking about this with another colleague, Meredith, that, one of the things that is a clear sign of this is that if your integrated behavioral health within primary care is focused on mental health and substance use, you are making it more specialty. Like you just are. Now, again, that's not to say that's wrong. That's not to say that isn't serving a function and a purpose. But when we are talking about this as like identity within PCBH, within primary care, if that's the focus, automatically you're already making it more specialized. You're already making it as more specialty.
And I think I know the answer to this. But what would be, there's not right or wrong. It's just if something is functional or not. In what way might it not be functional if you're coming into a system, kind of like us, guns a-blazing, of like, I'm going to address all of the mental and behavioral health stuff that's going on. And I know that we wanted to work on medical conditions, but we never really took a lot of time to like actually look at the goals. But like, what is the harm of doing that?
From
a functional
perspective, I think there could be a lot of functional things about taking that perspective. It can help offload the PCPs and really just, on the behavioral, the mental health and the substance use, like that could be a functional thing. Where my mind goes, though, is that it will be essentially finite, though, just from the beginning, because there's only like a select group of people that you can help, because there's only so many people that have mental health and substance use.
Or will identify that.
Or we were
identified as that.
And I love that you said that, because what were we talking to our yesterday's webinar about? We were talking about anxiety, and what did we say?
Yeah, the physical manifestations. It doesn't always manifest that way. So back to what you're saying. So it's finite if you come in guns a-blazing, trying to make everything mental and behavioral health.
Correct. And the other thing that happens with this too, if we start focusing on mental and behavioral health, there's also, my mind just says, let me know if you agree with this, because I maybe like a 50 to 60% probability that it's true. There's also this risk of very much, since we're approaching it as like, hey, mental health and behavioral health concerns or mental health and substance use concerns, there's a way of treating that.
Okay.
And that includes, again, protocols, that includes like the certain level of care. We can predict who needs what versus, again, a primary care. And we talked about this in another corner. Primary care really aligns with like a single session approach, because that's what primary care does. Primary care, hey, we're comprehensive care. First contact, let's see what we can get done.
Yes.
At the end of this visit, we'll see if we need anything more. If we focus more on mental health and substance use, the probability of doing like a primary care single session mindset, my mind says, just goes down.
Well, yeah, because as we were saying, it doesn't make sense to hunt down a warm handoff and do a 12-minute visit, because that 12-minute visit isn't going to be fitting into a nicely defined protocol. And the other big one, which is probably still in your brain, so now I'm going to do what I always do and steal your thunder when you're right about to say something.
No, just say it.
And I want to say it. It stunts integration efforts.
And how so? How so?
You're not rowing in the same direction as the rest of the team. So you look different, you act different, everything feels different. It's like a different line of service. So if one of the missions that I know that you and I have is joining in the definition of the high quality primary care, which is being able to provide services to families, individuals, in the way that they would want it, in a very relationship-based, person-centered, beyond even just patient-centered, but person-centered, and for all ages, right? And so that's what we're trying to be a part of. But if we come in with a different perspective, then all of a sudden we're not part of that same definition.
And as you're saying that, my mind is having this, we talk about this regularly, but another epiphany that comes up throughout this is that can be jarring for a new behavioral health provider coming in, right? That is, as we said, like just, not almost like completely unaware sounds like negative, but not to their fault, not on their, because this is how you're trained and stuff. And kind of all this, like, why am I not part of the team? Why am I not being uptaken as much as possible? Why is this happening? It could be because of us just not embracing that identity as a primary care provider.
Or even like knowing to embrace that identity. And so you just become overly fixated on making everything, like you said, protocolized, that there's a specific treatment. You're not looking at it as, how can I get something done in this moment? How can I be longitudinally a part of somebody's team? How can I be part of the population-based reach? It's actually very hard to articulate.
And the thing that becomes up to this too, even beyond the 4 C's, kind of made me getting a little bit more granular, like implementing high quality primary care. Primary care is chaotic. There's a lot of things going on. You ever go into a primary care clinic? I love it. You can just feel this energy that's coming. People are running around, people going in and out of exam rooms, you're getting interrupted and stuff. That isn't a very specialist mindset.
Right.
That's a different way of approaching care. And the one thing that I'm trying to think, who was I talking to? I'm assuming it was you and I that were talking about it, but maybe having the identity be that I am a behaviorally trained provider working in primary care. So rather than being that I'm a behavioral health provider, I am a behaviorally trained provider working in primary care. Because it's almost kind of like juxtaposed into the medical side. What the medical is that they are a medically trained provider working in primary care.
I like that.
Yeah, so for us as well, looking at it, it's like, well, what would our identity be? It's like, you're still a behaviorally trained provider.
Yes.
That is your expertise in primary care.
And when you do that, the mission that we're on is making mental and behavioral health providers a regular member of the team. That you are as regular of a team member as a medical assistant, the nurse, the PA, the NP, the MD, or the DO. So that like in 10 years from now, hopefully less than 10 years, but I don't know, we'll see. If you go to your primary care, your family, let's use the word family medicine, you go to your family medicine clinic, that it would be as normal to expect, well, of course, at a family medicine clinic, you would have a physician or an NP or a PA or all of the above, right? Of course, you're going to have a nurse. Of course, you're going to have an MA. What if everybody expected, well, of course, you're going to have a licensed mental health professional? And again, not that they're this separate service, a co-located service only, but that's an integrated team member. You expect, the MA is going to walk in, the nurse is going to walk in, the PA is going to walk in, the BHC is going to walk in. What if that was, and I guess that's when I was going off on my little meanderings about high quality primary care, this is the vision that I want to have.
Could you imagine every single person having the expectation they have a provider that is behaviorally trained?
Yeah.
That works with them in primary care.
So if something that's comes up that's behaviorally related, so maybe you're talking to your physician about sleep issues, and maybe there's a prescription, they prescribe you that, and there's this expectation that, well, of course we're going to talk about all the behavioral techniques. So of course they're going to come in and talk to you about your sleep. Of course they're going to talk to you about your mood. Of course they're going to talk to you about your exercise habits because it's behaviorally based.
It makes, and this is we've talked about this before, when we take that approach, what you just described, and embrace that, rather than it being a finite amount of people that we can help, it literally is
full circle.
Infinite. It is literally infinite, the communities that we can help. Because someone comes in, as you said, sleep concerns. Now, we could say that could be a behavioral kind of thing, like a mental health and substance use thing, but we almost do it in ways like it's a disorder. It's related to someone not being able to sleep well because of some other mental health condition. What if it was just, we're going to help this person them improve their sleep?
Yeah.
What if it was, we're going to help this person take their medication? We're going to help this person give themselves insulin. We're going to help this person take their inhaler the way they're supposed to as far as dealing with asthma. What if that was what we were doing?
And I would say that being at CHCW for going on 11 years, well, this is year number 11, that I don't know if the handoffs always come in that fashion. Sometimes they do.
Yeah.
And some folks that I've been working with who maybe got to me originally because of panic attacks or some other thing that was labeled as mental health, I now as a clinician, as a BHC, I pay attention to this stuff. I pay attention to what's going on in their medical visits. I check in about when they have medical visits, what's going on with that. And then I'm always looking for ways that I can support them in that moment. Even if we happen to be working on something separate related to anxiety or depression or something a little bit more traditionally mental health. And that's something that you can do. And it gives you so much freedom as a clinician. It takes the pressure off that somebody who maybe is in the pre-contemplative stage or the contemplative stage, or maybe they're not fully ready to work on depression. But you can help them to just be able to manage their health better. All of a sudden as a clinician, those 22 minutes that you get together or the 34 minutes that you get together are super meaningful.
Yes.
And it's not defined by the disorder that the person is experiencing.
Correct. And it's super meaningful not only to the patient that you're describing, to the healthcare system, to the PCP, the other team members and stuff, keeping that person engaged and allowing us to be able to give, because again, we're behaviorally trained providers, that we can give information to our team members, like, hey, this is what's going on. So now they're responding more compassionately, more flexibly to the patient. As you were talking again, it was, I just got done reading the new motivational, well, it's not new, it was in 2022, the second edition of the motivational interviewing for healthcare providers. If you want to feel like, hey, I should take an identity as like a primary care provider or as a healthcare provider, that is a book. You go through that book and it's like, this is us. This is like...
What is it called again? Motivational interviewing?
For healthcare professionals, I believe. 2022, second edition. And it really is this reminder of like, oh man, everybody talks about MI, in the spirit of MI. It's like, you get someone who's behaviorally trained in a system, that stuff just starts to grow and exponentially grow, and it just becomes interesting. And then I think this is the other thing that, to come full circle as well, looking at, this is our belief, that I think this is a big, a really important thing, because even a recent grant that we applied for about integrating within primary care, it was focused on mental health and substance use, like it was. So I don't think that's wrong. I don't think that's wrong. That's not necessarily our approach. It could still have a function. So grace, love, and compassion, if that's not kind of the purpose of the group, and I want to come back to that as well. But whenever we can make it a healthcare intervention, and not a mental health or a substance use intervention, again, you're
just going to get more reach. And back to that person-centered, relationship-based primary care service that we're providing that to the whole population.
Everybody in I love how you said it. Gets me so hyped because again, I think at CHCW we're seeing this a little bit more. I know Angela, our CEO, sees this as what happens when the expectation is everybody gets a provider that's trained in behavioral.
Yeah.
That's a really cool,
it's a cool concept.
That's a cool concept to think. The last thing I wanted to end with, I think this is an important thing, for people that are going to jobs and different things. This is why when you're being interviewed for a job, and we do this in your lab, about making sure the people that you're talking to, what are the goals of the integrated care?
Okay.
Like, what are the purpose and the function? Because the one thing I wouldn't want people to do watching this video is like, well, Dave and Bridge said I need to be like a primary care, but my system isn't wanting that.
Right.
My system is more wanting, hey, we just want someone to be able to, and just that sounds bad, but we want someone just to focus on, mental health and substance use.
Right.
That's not wrong. And it's another thing to be asking yourself when you're interviewing, when you're going into your systems, what is the vision of this? What is the purpose? How are our values aligning? And really trying to, as much as possible, move it towards, at least from our opinion, move it towards a more primary care, universal, high quality definition.
Yeah.
Yeah.
My mind was going in like 6 different directions, which is why I have that pause right there.
Yeah.
I think that for now, I think it would be good to kind of wrap up.
Do the George.
This corner.
Okay.
But my mind is coming up with all kinds of different ideas. And then also I was thinking about, for the audience, that this corner actually might be more confusing. Back to this last point you were saying, it's like, well, Dave and Bridge said it's not mental and behavioral health, but you're trained as a behavioral health providers, so it can be very confusing. If this corner prompted more questions than answers, that is okay.
Maybe it should.
And
maybe we should be asking this a little bit more.
And ask those questions, because we can have some follow-up corners to try to, dig through this nuance. And I think, again, coming full circle, and we will wrap it up, I promise, that our role as BHCs, if the vision is to be a regular member of the medical team, you just have different steps and different approaches that you take.
Yes.
Now, if you have different set of goal at the beginning, and say it really is that you want to bring co-located specialty services to an agency, that's not wrong or bad. It's just the behaviors that you would do, the things that you would have on your radar, what you'd be expressing in those interviews. It would just all be different.
Yes.
It'd be different dependent on the overall vision. So our vision that Dave and I are mostly talking about,
Correct. Our truth criterion.
is how to make the behavioral health providers be a regular member of the medical team in primary care settings.
Exactly. And that's, I really do like that. The truth criterions for those different, just might be different. And so the behaviors might be different. Yeah.
All right.
I'm excited to hear about your other thoughts.
Well, we're going to shoot it right after this. So you'll see us wearing the same clothes, even though it'll probably be 2 weeks. It'll be 2 weeks in between.
There we go. Well, thanks as always. Thanks for stopping by.